Hello, ESOT community. I am Jelena Stojanovic, consultant pediatric nephrologist at Great Ormond Street Hospital for Children in London. I am a EKITA board member, and I am also a board member of the pediatric donation and transplantation subgroup of the LPAT section. I'm delighted to have been invited to give a presentation on why is pediatric transplant recipient in 21st century a challenge. So we'll start by defining what a challenge is. According to the Collins Dictionary, a challenge is defined as something new and difficult, which requires great effort and determination. And for those of us who are using Merriam-Webster's dictionary, a challenge is defined as a stimulating task or a problem. So how does this translate into today's generations? This slide shows the last 3 generations, and the presentation that I'm going to give will focus on the children that were born after 2010. This is the generation Alpha, and these children have established themselves as the decision makers. So why are we talking about pediatric transplantation? Because pediatric transplantation brings ever-evolving challenges, and because childhood is the most important period in one's life. This is the period when we grow and when we get our education, and also when we reach our social milestones. So if you are to go and find a member of the generation Alpha in the general public, you'll probably find them in the park, but they will be playing slightly differently than most of us used to. And if you are to look for the pediatric kidney transplant recipient, you'll probably have to visit the neonatal unit. Over the last couple of decades, advances in the neonatal medicine have actually led to us nephrologists now receiving a new generation and a new profile of the transplant recipient. Lung hypoplasia is not a problem anymore. Therefore, children who are born with congenital anomalies of kidneys and urinary tract, most of which were associated with lung hypoplasia, used to not survive outside the neonatal or infancy. However, today, due to the advances, as I said, in the neonatal settings and in the work that our colleagues neonatologists have done, these children would survive, but would be left with end-stage renal disease. This was brought to our attention 20 years ago. Malcolm Coulter, nephrologist from Newcastle upon Tyne, and colleagues have done an excellent overview defining the profile of the children who reach end-stage renal disease and therefore require dialysis before the age of 2. This means that pediatric recipients are likely to need neonatal dialysis. However, due to the prolonged stays in the neonatal units and comorbidities, we might encounter some problems with vascular access or the lack of it. The comorbidities are likely to complicate peritoneal dialysis. And these children are likely to be sensitized due to the multiple blood transfusion that they might require in the neonatal period. And there is our first challenge, that we are now facing the newborns with end-stage renal disease who will require dialysis in the neonatal period or in the early infancy. And with no doubt, they will come with multiple comorbidities. The causes of end-stage renal disease in children have not changed greatly in the last couple of decades. Majority of children will have congenital anomalies of kidneys and urinary tract as the leading cause for the requirement for kidney transplantation. But what we do know more now, and what we have managed to define, is this other group. Those are the children who have various metabolic conditions who are coming up for transplantation, such as methylmalonic acidemia, primary hyperoxaluria type 1, or cystinosis. This other group also has complex renal transplant recipients, most of which will require more than one solid organ transplant in the childhood. So the small recipients, but big challenges, big surgical challenges. We now know that there are excellent clinical outcomes in the short and medium term when it comes to the surgical aspects. So the colleagues from Germany have published their work on transplanting 40 children who were less than 11 kilograms at the time of transplant. Colleagues from Brazil have reported their practice on 62 children who were less than 15 kilograms at the time of transplant with excellent clinical outcomes. And with no doubt, alongside with surgical advances and successes, we have learned a lot more about the perioperative management of these small recipients. In London, where we have 2 pediatric renal transplant centers, we have looked over 453 pediatric recipients, and in our cohort, 68 children were less than 15 kilograms at the time of transplant. And this box plot shows that the graft function and patient survival in the small recipients compared to the children who were larger at the time of the transplant were actually comparable, and that there was no difference. We also now adopt a policy, no vessel, no problem. A lot of the children who would require various interventions in the early neonatal and infant periods might have lack of major abdominal vessels. The picture on the top left shows the absence of the middle part of the aorta or the abdominal part of the aorta. And the picture on the upper right shows the venous collaterals, which have formed due to the lack of the inferior vena cava. In our center at Great Ormond Street Hospital, we have successfully transplanted both children. And Professor Nizamamod, the transplant surgeon, and his team have actually proposed a classification system for the major abdominal vascular anomalies for complex renal transplantation in children who have anomalies of the aorta and IVC. Around the same time, colleagues from Japan have also published their experience and successes in transplanting children with complex vascular anomalies. What we also can do is to use the 3D printing in clinical practice, and this is actually shown to be very useful. We can use the images from the magnetic resonance angiography or from the CT images to actually form a 3D model. As you can see, the picture on the top left shows the aorta, which has an aortic bypass and early bifurcation of the aorta. And the model on the right also shows how does that look into the practice with the donor kidney. So what this model has actually allowed is for our surgeons to identify prior to surgery the window for the arterial anastomosis. We have over the years progressed, and our models look slightly more colorful and look better. The use of this was also recently published by Nizamamod and his colleagues, and the importance of using this model is not only that it enhances the safety of the surgical procedure because it allows for the better pre-operation planning, but it is also very useful when consenting and obtaining informed consent from the families. Alongside with surgical, we have also encountered some medical challenges in this cohort of patients. And this is when we start to talk about the incompatibilities. So what does the incompatible mean? It's something which is incapable of harmonious coexistence, or something which is incapable of blending into the stable homogeneous mixture, or maybe unsuitable for the use together because of some undesirable chemical or physiological effects. In transplantation, this would mean transplanting an organ into a recipient who is a different blood group or who has current or preconditioning donor-specific HLA antibodies. So what can lead to the sensitization? Well, for the blood group incompatible transplantation, we only need to remember the Landsteiner's law, where the antibody is present, but the antigen is absent. And for the formation of HLA antibodies, for females, there are 3 sensitizing events, and for males, these are only 2: previous solid organ transplant, blood transfusion, or a pregnancy. In mid-60s, with the discovery of azathioprine, just like the adult transplant recipients, Pediatric transplant recipients have benefited from the use of azathioprine, which has actually started the modern era of transplantation. However, the hyperacute rejection, which can be seen in incompatible transplants, still remains an issue. So what are the options for children who have no compatible donors? And this would depend on various factors. Most importantly, which country these children live and what's available to them. Some children would need to go on a deceased donor waiting list. In some countries, living donor paired scheme might be an option. We might also decide to proceed with antibody incompatible transplantation or decide to leave children on dialysis, which is something that we shouldn't do. And that really is not an option because children need to grow and to be educated. Why would we want to do an antibody incompatible transplantation? Because of the shortage of compatible organs, because of the well-known benefits of living versus deceased organs, because we want our children to be dialysis free and to improve their quality of life. In our center, we offer enrollment into the paired scheme first. There are increasing number of reports now, even for also for pediatric population, about the good short and medium-term clinical and patient outcomes from various groups when it comes to antibody incompatible transplantation, and also emerging reports on successes of HLA incompatible transplantation in children. A paired scheme, or formerly known as living kidney sharing scheme, is well-established transplant program in the UK, Spain as well, and there are also, it is also becoming more popular in other countries as well. This is when children who have incompatible blood group or HLA incompatible donor get enrolled into the national scheme and might receive a kidney from a different donor pair who also enters the scheme because of the incompatibility. So why would we do something which has a high risk of rejection in children? But maybe we should ask ourselves, why not? It's a critical phase in one's life. There are worse outcomes if children remain on dialysis, particularly when it comes to their cognitive development and growth. We want to improve their quality of life and give them the benefit of a better quality organ. However, we do not have the number of data on the number of children with blood group incompatible donors. Children do have immature immune system and are at an increased risk of an infection. And there might be some concerns about the technical and practical issues about the antibody removing, in particular, small children. But children will have low titers. So this forms the second challenge. The transplant recipients are smaller at the time of the surgery. They might lack major vascular vessels, and the shortage of organs might drive some higher immunological risk transplants, and this could give rise to some of the infections. So we are able to transplant children when they are small. We can dialyze them when they're little. We successfully perform antibody incompatible transplantation. We can 3D print their models. Surgeons have excelled in their expertise. And then they become teenagers. And when they become teenagers, they fall in love. They fall out with their parents. And more than not, they stop taking their medications. This is a local study which has looked into the 170 patients, of which 15 grafts failed before they were transitioned to the adults. 3 of them has early surgical complications and disease recurrence, but 12 children lost their kidneys for various other reasons, as you can see in this graph. And 1/3 of those lost it because of the non-adherence. So medication non-adherence is a huge issue in adolescence and is one of the important causes of the graft loss. So that is our third challenge, the graft lost in childhood, particularly during the transition period, which is crucial in one's life. And the learning that transition is a process and transfer of care is an event. I'd like to also spend a couple of minutes just talking about the advances in the liver transplantation. The hepatobiliary surgeons have excelled now and are able to reach excellent outcomes, clinical outcomes for children who receive the transplant, even if they are smaller than 4 kilograms. This is a paper from colleagues at King's College Hospital a couple of years ago showing excellent outcomes of liver transplantation in small infants. From Stanford and Pittsburgh, leading centers where liver transplantation happens in children for inherited errors of metabolism, they have also shown some long-term outcomes of children who have received combined liver and kidney transplants for inherited errors of metabolism. So this brings to us the new wave transplants. We are having increasing number of children who have combined liver and need for combined liver and kidney transplants. There are children who will have heart and liver transplant or heart and lung transplant. And there are also children who have more than 1 or 2 solid organ transplants at the same time. Those are rare patients, but children who come with that need for a small bowel, liver, and kidney transplants. Alongside with these very new and complex transplants in pediatrics, we are able now to try and share the experience and identify some of the predictors of the outcomes for example, combined and liver transplantation, or maybe look into some special considerations when considering transplantation of a combined abdominal and thoracic organs. So I'd like to finish this presentation by telling you what the future looks like for pediatric nephrologists and also for us, for you adult nephrologists, because these patients will be coming your way. This is the patient who we transplanted last year. It was a 3-year-old boy who had a genetically confirmed methylmalonic acidemia, Williams syndrome, and renal dysplasia. His weight at the time of transplantation was 12.4 kilograms, and he had simultaneous liver and kidney transplant from deceased donor, the same donor. His liver transplant was for enzyme replacement only due to the methylmalonic acidemia. He received left lobe of the liver and the right kidney. But because of his small size, we were unable to close the abdomen at the time of the surgery, and he had delayed abdominal wall closure for 7 weeks. We then proceeded and did the recti muscle fascia transplantation from a deceased donor. He's now 11 months post-transplant and has an excellent function of both organs. He has grown with the current weight 18 kilograms and height increase of 4 centimeters. He also has shown some developmental progress. And this work is credited to the multidisciplinary approach, which has involved 4 hospitals, 12 specialties, but all working as one team. I will now be showing some photographs, which I have the kind permission from the parents of the patient to share with you, and by the operating surgeons Nikos Kesaris and Lyle Yassin. So this photo shows the surgeon on the left with his left point finger showing, pointing towards the newly transplanted liver. You can see the small bowel, and this was the time before we were to implant the kidney. Therefore, you can imagine the challenges that our renal transplant surgeons must have encountered. This is how the abdomen looked after the successful implantation of the kidney. And this is how it looks several weeks after that. So still unable to close the abdomen. We then put on call for the abdominal muscle recti fascia. And this is how the implantation looked like. This is how the abdomen looked at the end of that surgery. We were able to close the abdomen. And this is a picture which was 3 months after the surgery was done. We were able to maintain and to preserve even gastrostomy. So how well do those children do who need more than 1 solid organ transplant? What is their quality of life? To date, there are very skim reports in the literature on that. We hope to get more information from the unique study, which is the 20-year study looking into the UK data, which compares and looks into the clinical outcomes, but also quality of life of children with multi-organ transplants. The pilot data from 25 patients who were transplanted in London in this period showed that there is a graft function which is good and comparable to all types of single organ transplant recipients as reported in the literature, that multi-solid organ transplant recipients had fewer episodes of acute rejection, and this is for both kidney and the livers, which is majority of our patients, but they had higher risk of complications, which include surgical and medical ones. Quality of life in these recipients was comparable to the pediatric single organ transplants as reported in literature. The average score, quality of life, was 76.6. And some of the things that our recipients flagged were treatment anxiety, which understandably was less present in the younger recipients, and maybe some concerns about the future. But definitely we have discovered in this pilot study is that individualized approach and personalized transplant protocols with multidisciplinary teamwork are the way forward for these complex recipients. So the generation alpha is coming your way. Are you ready? They are more complex renal pediatric transplant recipients. They are smaller in size at the time of the transplant and come with both medical and surgical challenges. They do have good graft and patient outcomes in the short and medium term, but they're definitely forming a new generation for the adult nephrologists. They're more than not likely to come with more than one solid organ transplant, with not such great vessels, and with compromised peritoneum. The comorbidities are new and complex, and sensitization is guaranteed, and they are coming your way. Thank you for your attention.